Let's get started, everyone. Welcome. This is the VCU Department of Internal Medicine Grand Rounds. Today is December 12th, 2024. Today's session is sponsored by the Division of Geriatric Medicine. We're going to be talking about the continuity of care for older adults and the importance of an integrated healthcare system. Joining me today is our division chair, Dr. Peter Boling, who's been here at VCU since 1984-85. And he'll share a little bit about his personal stories, navigating through the health system through the years. I will be talking a little bit. My name's Christian Bergman. I'm an associate professor here in the geriatric division. We also have Kate Rackson, Dr. Catherine Rackson. She was at GW for her residency, completed fellowship at Duke, and joined us here at VCU in 2015. And she's the medical director for the home-based primary care, previously known as house calls. We also have Dr. Julia Breton. She was at Tufts University, followed by fellowship at the Harvard Combined Program, and joined us here in 2021. She is medical director of the Continuum Integration Center, as well as the co-medical director of Hospital at Home, and also involved in remote patient monitoring. There's a lot of stuff going on there. And lastly, Dr. Michael Weissberger. He did his training up at Thomas Jefferson in Philadelphia for his residency and geriatric fellowship, and he joined us here in 2020. He is the medical director of the ambulatory clinics in geriatric medicine, as well as a physician informaticist for the health system. And he's going to talk to us a little bit about the physician builder program within EPIC, and also wants everyone to know that you can challenge him in Ultimate Frisbee. He is a phenomenal player, so careful. All right, so let's get started. We're going to be talking about the importance of an integrated healthcare system. I already introduced our speakers today. We have no actual disclosures. VCU Health System does have a joint venture with Beata for the VCU Home Health and Hospice Agency, and we have some external contracts to work on quality improvement efforts within various nursing homes. There's some learning objectives here. Let's invite Dr. Peter Boling up to get us started.
Good afternoon, everybody, and thank you for the invitation. I'm happy to be here with several of my close colleagues in the growing division of geriatric medicine, which I have been the chief of since January of 2012. So this is 12 years in. And I have been here since 1981 when I was an intern in the Department of Medicine. So my job at the beginning here is going to be set the stage. I want to talk to you a little bit about what the heck is geriatrics, because I think many people don't know, and describe a little bit about what our various programs consist of, and then turn it over to the guys who actually do the work. So briefly, geriatrics is a field where we work on whole patients and all of their organ systems where they have common ground, which is that they are older individuals. So I'm going to go through a what, a why, a who, and a how aspect of understanding geriatrics. So as I said, we look at the whole patient. That is just different from most of the other specialties and subspecialties in medicine, where there's an organ system or a disease state that kind of defines the specialty. So aging is not a disease. We look at the knowledge that has been accumulated about aging itself, gerontology, which includes a lot of changes in our bodies. As you get older, you'll understand this on a more personal basis. I used to play Ultimate Frisbee when my knees were younger. I would have loved to have played with Mike back then. So, biology, anatomy, psychology, all of the bits and pieces of what makes us human beings. And then we look to apply data-driven and evidence-based approaches that have been gathered over time in terms of doing a better job of taking care of older patients, adjusting their care plans to be specific to the patient's age and condition, as well as the setting where they are located. And then, of course, we spend a lot of our time managing those chronic conditions that are most prevalent in older individuals. And across all of that, the division has focused its energies, as Christian started out to say, on coordinated care of the whole person across time and across care settings. I'll explain a little bit more about why I think this is so important. But in general, for best results, you can't really take great care of an older patient with multiple health problems if you approach them as an individual with a collection of organ systems managed by a cadre of physicians who don't ever talk to each other, one or two per organ system, which is unfortunately how healthcare has sort of devolved over time. Why? Why is because we all want better care for our older patients. That's reason 1, 2, and 3. And then finally, when I was in medical school, I took a side interest in healthcare finance and health policy as an interest. So that's been with me since the beginning of my career. I've learned a lot about it over the time. And so at the end of the day, we all want a more efficient healthcare system. The hospital and the health system needs to run efficiently in order to take best care of patients. And we need to achieve that at lower costs. Our costs in this country and in our organization are out of control. So in order to really be most effective in this regard, you have to concentrate on a population-based approach. The population can be segmented into groups. In the top part of this pyramid are the people that use the bulk, the larger share of the resources. Those are people that have usually advanced and multiple chronic conditions. They go in and out of the healthcare system, travel through it in various ways. And that group is the group on whom we have the greatest with whom we have the greatest opportunity to make a dent in the cost curve in the short term. If you think about long-term primary prevention, disease management of the people in the lower portions of this pyramid are going to pay dividends and return value. But if you think about the short term and you want to bend the cost curve, it really has to be up there at the top. This is just highlighting similarly the more details. These are Medicare data from years ago, but they've been the same down through time. At the very top, there's a little slice. These are people who've been run over by 18-wheelers and who have developed some really profoundly complicated disease state. They're really difficult to change their trajectory. That group maybe represents a small slice at the top, 15% of the cost. The group of greatest interest to us is the next two buckets, which are over 40%, maybe even 50% at times. Those are people with serious health conditions, chronic usually, and managed over a span of time. And if you think about this, the people at the bottom of this, use 4% of the resources. That'd be like most of us listening to this conversation. Whoops, gotta be on this side. So now I'm gonna switch over and say we have a whole bunch of people doing this work here. Now we have 18 physicians representing 17.4 FTEs in the division of geriatric medicine. We have, I think, 22 or 23 nurse practitioners and PAs. We're running 4 clinics and we have multiple other sites. We're going to talk to you a little bit more about all of those. I'm going to, hand it over in just a second, but look at this big green box here. You can see the pointer moving around. This green box is meant to represent all of the older persons. Down here at the very bottom is a group that we see sometimes who are in the bright blue box. These are people who are doing great. They want to live to an advanced old age. They're very functional. Their goal is to achieve longevity and healthy longevity. We see some of those people and it's fun to see them, but more of our time is spent in these other domains up here. So on the left-hand side, we spend quite a bit of time with end-of-life care and palliative care, working hand in glove with the Division of Hematology, Oncology, and Palliative Care. And we spend a fair amount of time over here with patients that have neurocognitive disorders of one kind or another, dementia, precursors to dementia, delirium, depression, and so on. And we are initiating a new program for supportive care of dementia patients this coming summer called GUIDE. This group in the big blue circle are the ones that we spend most of our time with. They are sick. They have a lot of chronic health problems. And in the center yellow box is the hub of what we all do. So as I mentioned, 2 advanced health homes, team-based care in clinics, home-based primary care, we'll talk about that in more detail, transitional remote monitoring, and a transitional clinic that Julia's told you about on other occasions, we'll mention. The nursing facility care team, Kristen's going to fill you in. Hospital at home, you've heard about, we'll mention that in passing. This is a constellation of programs that we put together to take care of patients across the continuum. We've started a home health agency in hospice. Those are not in the division of geriatric medicine. We're providing a lot of support for the development and implementation. And then finally, inpatient consults and co-management are an active part 365 in the course of the year. it would be wrong to leave this without mentioning the 4 M's, or depending on who you are, the 5 M's of geriatrics. So the 4 M's, what matters most? That's if you're an older person, your goals may be really quite different from how they were when you were 25 or 30 in terms of what's most important. Is it most important to live as long as you can, or is it most important to be able to walk around, talk, feed yourself? What are the priorities? Medication management, trying not to poison older patients with drugs that are bad for them. Mobility, maintaining patients' activities of daily living, and then mentation. The 5th one over here that we've added is multi-complexity, because if you think about it, the ones that consume most of the effort are the patients with multi-complexity. This little wheel is representing all of the different bits and pieces of our portfolio of services that we've organized to help take care of this group, and that's going to be the theme on which we'll base the rest of the talk.
Hi, everyone. I'm Kate Rackson. I'm the Medical Director for Home-Based Primary Care. And I'd like to talk to you a little bit about our program, the area that we service, what we do on a day-to-day basis. And I'd like to introduce you as well to our team. You don't see us a whole lot. We're often on patients' doorsteps and in our car offices. And so we don't have a lot of face time with you all. But I'd also like to go through the process of making a referral to us. We are taking new referrals, and we'd love to help your patients. So we turned 40 years old this year. This is a program that was initiated by Dr. Boling. I believe it was a 1-physician practice with a map on the wall with pins in it. So here's our map with pins right now. We've expanded a good deal since then. And I'd have to say, if I was relying on a paper map and my own sense of direction to get from house to house, I would not be standing in front of you today. I'd still be on my way home. And so in any case, we are servicing patients within 15 miles of the downtown campus. Every pin that you see on this map represents a patient that we're seeing right now. A couple of outliers have moved since we've admitted them to our program, but we see people within 15 miles pretty strictly, just so we can serve them as often and be available for urgencies as they come up. And our census is currently 383 people, and we have the ability to grow right now. We are taking new patients. Every different color you see on the map is a different nurse practitioner MD team that sees the patient. We're arranged geographically, again, so that we can provide patients with services when and where they need it, and so that they have better access to us. And so from start to finish, how do we take care of a high risk, high needs patient with multiple comorbidities? How do we take care of this population from start to finish? It is a team-based practice, and we need every member of the team. Here's our Okay, I'm stuck. There we go. Here is our admin team. So when you place a consult, this goes directly to our admin team, and they come up with a time. If there are urgencies or questions, they reach out to the physician. When you call our practice, there is a human being that picks up the phone. There is no phone tree. And they escalate urgencies, they take care of intake, they take care of scheduling. That nice geographic picture that I just showed you, they're responsible for that. And so we're very grateful for our admin team, and to probably interface with them. We have 2 social workers. Before a physician even sets foot in the home, the social worker has come to do a psychosocial assessment. They screen for depression, they screen for housing issues, medication issues, food insecurity. They work closely with APS workers, identify hazards and problems before we even enter the home. And they help to come up with long-term solutions for these, and help to also meet the immediate needs of our patients too. And we all know that we cannot provide medical care for a patient until they have food to eat or a house to live in. And so those are our social workers. They also provide therapy for our patients, which is a service that many of them need. They can provide face-to-face therapy. These are our RN case managers, and so they are available through the day for triaging urgent, non-urgent issues. They provide tremendous support directly on the phone to our patients and our caregivers, a tremendous amount of case management that Robin and Marcia are doing. And so every patient that enters the program has either Marcia or Robin as their primary nurse, taking care of issues as they come up through the day and escalating them to the MD NP team. And so here we are. So here are the nurse practitioners and the MDs, many of which, so several have been here for upwards of 20 years. And we have some new faces up here as well. And so our goal is to provide intensive in-home primary care services to patients. We are available for same-day urgent visits as well. We try to be as available as we can to our patients, and we have frequent follow-ups. So our schedules allow us to see patients approximately once a month if they need it. Once a month to every 6 weeks, we tend to see patients, and patients end up being seen about 12 to 15 times in a year. And this can vary from patient to patient, of course. So, so here we are. So how to make a referral. So being home limited, generally speaking, this is a taxing effort for someone to leave the home due to a medical or a mobility issue that they have. A couple things, we have so many wonderful primary care doctors and providers at VCU, but they have to be willing to change providers to come and see us. And we don't like to disrupt that relationship, so we just appreciate if you make the patient aware before they switch. They also have to be willing to accept primary care at all. It's very difficult when we go to the house and they actually weren't even interested in being seen. That sometimes creates a barrier for us. Our exclusion criteria, we really don't have all that many. Active drug use in the home, we don't see those patients because of the safety issue that presents. If someone is actively enrolled in hospice, we tend to think that the services are a bit redundant. We do not discharge patients when they go on hospice. We can continue to follow them, of course. Same with dialysis. Often scheduling becomes a problem if they are actively on dialysis. So currently we're not accepting patients under those circumstances. And then if they're outside of the 15 miles of the downtown MCV campus, just because of the drive time that it takes to get to them. Now, if you want to place a referral to us, it's ambulatory referral to home-based primary care. If you type home-based in Epic, it will come up. And so it's pretty easy to do. I'm happy to help troubleshoot if anyone has any difficulties with that. A stat referral, we can usually see in 2 weeks. We are not scheduling all that far out right now. I believe we're probably about a month out, if that, right now for scheduling. So feel free to reach out for your patients that are having some difficulty getting in. And you can always secure chat me if you have any questions, if you think someone might be appropriate, but you're not quite sure, happy to be available to you all. And lastly, so our patients generally do appreciate our service. They love being seen in the home, the convenience of it, and being able to do things in the comfort of their own environment. So, thank you very much. I'll hand this over to Julia.
No, it's Christian.
Sorry, we switched it up. Apologize. Thanks. All right. Thank you so much. I would just add one thing. We have a wonderful group of colleagues that help support all these programs after hours, which we did not mention yet. All of this work continues 24/7, 365 days. So there is a fairly robust team of after-hour providers that help support all this. I'm just going to mention that I'm going to be talking about the nursing facility attending service, which in this bubble of services that we have is here, it's called the SNF attending service. It's pretty self-explanatory. Our main mission is to see patients leaving VCU Hospital, which now includes folks that are leaving Tappahannock or Community Memorial Hospital down in South Hill and are coming up towards Richmond or down to Richmond for rehab services. So the health system has an administrative relationship or a preferred network. We have 8 facilities here in the Richmond area. So it is fairly busy. We're seeing about 100 to 130 SNF admissions, hospital discharges every month. So it's a team-based effort. We have 4 teams, MDs and NPs. These are our teams. We're broken into 5 different teams. Henrico, Hanover, Lakeside, Beaufort, Westport, Glen Burnie, and Southampton. Canterbury is to come soon, but you'll see these names a lot because most of the inpatient referrals end up going to one of these facilities. We do have some medical directorships, 3 currently. The purpose of the medical director is for VCU Health to understand challenges that are occurring in the day-to-day operations within the facilities that impact quality of life and the quality of care that residents are receiving. So when you are the medical director, you are more involved in the day-to-day operations, and VCU does not own any of these facilities. So it's important for us to have some insight into challenges on the front line so that when we are discharging, we have a patient from the hospital who requires very intense need. We have somebody that can help troubleshoot some of the care processes that might break down, whether it's during the care transition or during the ongoing care of the resident. So we are building out our portfolio, being able to provide this administrative service. We also are fortunate to collaborate with VCU Physical Medicine and Rehab. In two of our buildings, we have Dr. Brittany Sway. She is a physiatrist with background experience in skilled nursing facility care even before joining VCU. So she has learners that she collaborates with. She works with the physical therapists, occupational therapists, speech therapists within the facilities to help enhance their recovery. So what do we do on a day-to-day basis? I'm not going to read the entire slide, but there are important care transitions that we want folks to be aware of. At the time of admission, it's really helpful if we are able to facilitate the warm handoff between the inpatient team and the skilled nursing facility medical team. There are challenges around medications. There are challenges around behavior, goals of care conversations that may have started on the inpatient side and need to continue. Those are all very helpful to facilitate via a actual phone conversation. So if you have a patient you're discharging, you should be getting a notification, and we're working to fix that program. But that is really important and helpful to do here. When we discharge somebody from the SNF back to primary care, it is expected that the providers in the nursing facility attending service send a message or send their discharge summary to the PCP, whether it's at VCU or not. We try to help facilitate that conversation. The other thing I will mention, just some advantages, and we are working on data to prove some of these things, but anecdotally, and we can share some of the Medicare shared savings programs. There is value in having this integrated system to reducing errors, predominantly the hospital to SNF discharge within 7 days. That initial return to hospital, where there's probably not a new clinical issue that is causing the patient to return. It's the process and the care plan that was designed in the hospital is not being followed through, either because of equipment, education, or whatever it is. Having a very integrated process helps that in the literature. And the other thing is regular inpatient presence, in the facilities. Our providers are in the buildings every day, Monday through Friday, so they're more likely to pick up on things. And because we are an integrated health system, we can then send a message to the surgeon or send a message to the heart failure team, cardiology team, infectious disease. If there are issues that we need to reach back into the health system, it's much easier if we have our own providers that are able to do this. We have grown a lot. This data is now 2 years old, but the main thing you need to know is that when a patient discharges from VCU downtown and they're going to a preferred network facility, almost 100% of the time now we are seeing the patients. So that is different from 5 or 6 years ago when we didn't have the capacity to be able to see that number of patients. So this is really helpful. The only instance where we do not see them is if they are returning to the facility. They're really long-term care patient under the care of another provider in the building. We don't overstep or reassign patients who have an ongoing relationship with another medical team. Things I need from you all is just kind of ongoing, collaboration. Know that we exist, but also collaboration back and forth. If you get a patient from a SNF, look at the notes previously and, send us a message. Hey, what happened? I got your patient on Monday, saw them on Friday. Can you tell me a little more about what happened? We can often provide some additional information. I'm going to turn it over to Dr. Breton now, but thank you all.
All right, so also in the continuum of care, of course, is hospital care. So I'm going to talk a little bit about one of our innovative clinical programs called Hospital at Home. Now, Hospital at Home is actually for any adult. We've taken care of patients ranging from age 18 to 103, but today I'm going to highlight some benefits that are particularly exceptional for older adults. So a quick definition, hospital at home is acute inpatient care provided in the comfort of a patient's home rather than in the brick and mortar. It is another unit of our hospital that happens to be located in a patient's home. This care model has been international for decades. It's more newly adapted in the US. Our hospital at home program here at VCU launched in 2023, and we have managed over 500 inpatients to date. Hospital at home is an evidence-based care model with decades of randomized control trials. There's many proven benefits, including safety, reduced rate of readmission. I'm sure you can imagine how much more effective our discharge planning is when we're actually in the home. In fact, our hospital at home patients have the opportunity to be a much more active participant in their care. And so one example is we have the opportunity to see how they're managing their medications. And for many of our patients who were previously managing independently, we're able to maybe simplify their medication regimen based on what we're seeing, some of the challenges they're experiencing, or help them organize their medications. And there's certainly been instances in which it's been made aware that they need some extra help managing their medications. So maybe we've gotten their permission to pull in family members or neighbors. There's also lower rates of infection, right? You don't get MRSA from your living room. There's lower rates of delirium in hospital at home. I would actually argue that it is the antidote to delirium. And considering that delirium is significantly associated with an increased rate of morbidity and mortality, this, if anything else, hopefully will inspire you to refer your older adults to hospital at home. A quick example of a patient with hyperactive delirium. She was pulling out her IV, hitting staff members in the brick and mortar, had to be sedated, restrained. And upon returning to her home setting in her own bed, a familiar environment, familiar caregivers, she left that IV in and was able to complete her IV antibiotics and have a much more peaceful and successful admission. And then on the other side of the spectrum are hypoactive delirium patients, my sleeping beauties. We had one such example of a patient was just really sleeping through her entire hospitalization, not participating with rehab, also not awake enough to eat or drink. And family and care team started wondering, maybe this is the end. But upon arriving back home, she perked right back up, started eating and drinking again. So it really has significant benefits. Kind of hand in hand, there's less use of sedating medications in hospital at home, right? People are less anxious and they sleep better in their own home. So we're less likely to need to medicate those symptoms. And of course, there's improved function. In fact, there was a study that showed that a hospitalized patient in a brick and mortar takes less than 200 steps in a day, which I don't know how many of you guys count your steps. It's really hard to take less than 200 steps in a day. And then a comparison group of hospital at home patients took almost 2,000 steps in a day. So that's a really significant difference. Our rate of post-acute SNF is way less than 1%, which is really impressive considering that a majority of our patients are older adults. We had a woman in her 90s who was getting weaker by the day to the point that she couldn't even transfer to a bedside commode without assistance. But her family brought her back home to receive the rest of her care in her hospital at home. And within 24 hours of just being in her own home environment where she could navigate, she was able to ambulate to the bathroom. And then, of course, I have to highlight there's a significant improvement in patient satisfaction. Our hospital at home unit currently ranks in the 95th percentile for likely to recommend compared to academic peers on HCAHPS. And just to quickly talk a little bit more about patient experience, it is really hard to be a caregiver or family member for a hospitalized older adult. That we know when you feel like you shouldn't leave them alone, they could really use your advocacy at the bedside. You have to drive downtown, park, navigate a big hospital, then you're stuck in this like really tiny room with no privacy, and you're like living on Panera for days on end. Just imagine like how much nicer it would be if your loved one could get all the same care but like in the comfort of your own home. They sleep in your own bed, you're eating your own food, you can continue with like your normal life activities. It also allows for the care of yourself while providing care for others. So and it's very, very common for folks to delay care, not just primary care, but also hospital care, because they have someone who's dependent on them, a dependent adult who can't be left alone or who can't be left with another caregiver. So they're able to still be there for that dependent adult, or maybe grandchildren who are dependent on them being home to have an adult in the home when they come home from school. And we've even had a patient who used to leave AME all the time because she had a lot of cats at home and no one to take care of them, but now she's able to receive her hospital care at home, surrounded by her pets. I'm going to skip through some of our criteria for the sake of time, and just really highlight, don't make any assumptions about what we can or can't do in the home and hospital at home. We can do a lot, and don't make any assumptions about what social situations we can or can't support. We've worked a lot on equity to try to make this a care model that really is for all. If you have a patient, especially an older adult, just enter home hospital assessment in orders. This notifies our screening team or enrollment team to start the screening process to see if they'd be a candidate. And with that, I'll turn it over to Mike.
Thanks. So I'm Mike Weissberger. Like Christian said, one of my hats is ambulatory medical director of our clinics, and that's not really what I'm going to be talking about today. My other hat is I'm one of the physician informaticists, and so I'm going to be talking more about the philosophy of how we enter data into the chart in geriatrics, which I'm hoping to convince you to simulate what we do in our clinical practice. So how you enter clinical data into the chart matters a lot. We spend all day long thinking about a patient's medical problems and then making medical decision-making and then writing that into our notes. A note is what I would call a continuous or textual or categorical variable, right? It's something that, like a note or a narrative or something you can free text into. It's really easy for us to produce. You can just go to the note, start typing, and it's done. The downsides of this kind of data is that it's not measurable, reportable. It's not what we call actionable. And it's, most importantly, it's really difficult to consume. You have to dig through these notes, excuse me, to find the one piece of information you're looking for or the multiple pieces of information you're looking for. It can take minutes, it can take hours, it takes a long time. So the opposite of that continuous type of data are what we call discrete data. It's much more granular. The meaning of the information is captured in where you document the information. And so while it may be a little bit more difficult to produce, you have to find the right spot in Epic to document something. It is measurable and reportable and actionable. And most importantly, it is much more easy to consume. You know exactly where to go to find the patient's last blood pressure. You know exactly where to go to find the patient's last input, right? So it is much easier to find that information when it's time to look for it. And the reality of our data are that people are consuming our information a lot more than we're producing it, right? Many people are reading the things we write, we're writing it once. So that's the first piece of this. What are some examples of discrete data? The medication list we interact with all day long, that's discrete. It looks like one piece of text, but actually it's the medication name, the dose, the route, the frequency, all stored separately. And this is important for things like medication ordering and transmittal of information, right? The vitals is also discrete. All of those pieces of information are in the flow sheet. And that's real important because let's say a nurse documents a hypotensive blood pressure, it may trigger a sepsis alert automatically in the chart. Couldn't do that if the nurse had just typed the blood pressure into the note. Speaking of our nursing colleagues, they are very used to documenting discretely. Almost everything that they document is into the flow sheet or in some other variable in Epic, and that's on purpose. They understand they need to put something where we can find it. And so discrete data helps us do that. So what I really want to focus on and convince you to start using is the problem list. The problem list is a discrete way to enter problems for patients. I think this is far and away the biggest data problem in our department. Many of us end up typing our problems into a note, which is, I think, the wrong place to put it. We all agree that the med list is very important, right? We want to communicate exactly what medications the patient is taking. It's actually quite difficult to interact with the medication tools. You have to use the historical documented medications. You have to order new medications with the tool, it would be much easier for us to write a medication name into a note and have something happen. But we all agree that it's important for the information to be structured into the record in the right way. Those are some examples of why we think the medications are important. You know, controlled meds need to go hit the state and federal database when we prescribe them. We have this concept of potentially inappropriate medications. We want Epic to flash a message when you try to prescribe one of those potentially inappropriate medications for older adults, and various other reasons why the medications are, why we agree medications should be discreetly entered. And like I said, we use these tools to enter these medications. I think we should be using the tools in Epic to enter problems in the same way. So lots of tools in Epic exist to do this. Many of us aren't using them, and I'm going to go over some of them now. There's something called problem-oriented charting. And along with that, something called diagnosis-aware notes, which is a new feature in Epic. There's admission and discharge navigators. There's various other tools you can use to get these information into the problem list. And then there's some carrots and benefits for having a filled problem list that we'll also talk about. So this is the basic problem, right? Is that when you see a patient for the first time or in follow-up, you have to go through 50 notes that have previously been produced by people, and finding all those gems of information, the diamond right in that haystack, the needle in that haystack, is really difficult. It takes forever. You might do this at home. You might do this before you see the patient. It just takes a long time. And I'm never sure I'm getting the whole picture, right? Because I can't read everything. On the right is an example of a problem list with a bunch of overview notes that describe each problem. It's much easier and quicker to read that problem list and be confident that it's a fuller picture of what's happened with the patient so far with their active medical problems. This is the primary reason that I think the problem list is helpful for all of us, and that it makes our work much quicker and more efficient and more accurate. So this is kind of that. So why would we do it? The problems are, first of all, the problems are shared with patients in my chart. There's a place in my chart where they can see their active problems. Having patients own and be aware of what problems they have, real important. When they go to see somebody not at VCU, when they're admitted somewhere else, when they're talking to their family about their medical problems, you want to make sure they know what they have. It facilitates communication with everybody at VCU. So, you know, when you refer a patient to somebody, or you return a patient with a recommendation to somebody, having your recommendations in the problem list is a really great way to say what you think that patient had, what your diagnosis is. On admission or discharge from our skilled nursing facility or acute care, it's a way to communicate very quickly what the patients have and what they need, what care they need to continue to receive. And outside of VCU, when patients go to some other Epic hospital, they can see our notes, but they can also see the problem list and all of our overview notes and assessment plan notes in the problem list. Also, other hospital systems like the VA and HCA also get a limited view of those active problems. They may not get the notes from us, but they will probably get a list of active problems. So how to do it? On admission, there's an admission navigator. You can take problems that exist on the outpatient problem list and activate them as hospital problems. You can add new hospital problems to the problem list, probably the reason that they're there you'd want to add if it hasn't already been added. On discharge, you do the opposite. You resolve acute problems. This patient probably does not have acute respiratory insufficiency anymore when they're discharged. And so that should not make its way onto the outpatient problem list. But they may continue to be managed with an active fracture of their lumbar or vertebral body, right? So that maybe needs to go onto the outpatient problem list. These tools exist to make it easy for you to reconcile the problem list on admission to discharge. And then at each ambulatory visit, I'd encourage you to add, remove, and modify those problems that are related to your specialty. So, you know, if a patient comes to you with a problem of shortness of breath, and you decide that they actually have asthma, you modify that problem to make it say asthma instead of shortness of breath, for instance. This is a quick overview of the diagnosis-aware smart links. The smart link names are .PROB-POC. That just shows you just the problems that are added to the visit and the notes that are added to those problems. And then the second smart link there shows you the associated orders. Basically, this is an easier way to type into the problem list. So you have visit diagnoses associated with each visit. If you were to add those visit diagnoses and then click on the special section of the note there next to that little blue line and start typing, once you sign or append your note, that little assessment and plan note will go backwards into the problem list associated with that problem. So this is a feature that people have really wanted for a while because people like typing into their notes rather than typing into the problem list. And this is a way you can do that. And I'd encourage you to explore those smart links. So why would you do this? You know, when you look around the chart, the medication list will show you your medications by the problems they're associated with. If you hover over a little icon in the problem list, you'll see relevant medication, associated medications and associated labs. If you're looking, my favorite actually is if you're looking at Haiku when you're on call or you're walking around the hospital, their problem list is right up top next to at the top of their list. And you can see the overview notes and read about what's going on with the patient right from Haiku without having to look at their notes. It's in Canto as well. If you're adding diagnoses and associating medications and orders with diagnoses, all the problem list is right there. Epic puts it right up front. And for me, the most compelling reason is all of our 50,000 messages in the in-basket we get every day, their current problems and the overview notes are right there listed with each message. So it makes responding much, much easier. I mentioned actionable, reportable, measurable. These are not things that we do every day, but the chart can be configured to give messages and best practice advisories, now called our practice advisories, based on their diagnoses. So you can have a pop-up that says, hey, are you sure you want to do this based on an active problem they have? You can use slicer, dicer, and reporting tools to understand your patient population and your practice patterns. This is a report I made about my patients with chronic kidney disease, different stages, and their RAS inhibition and SGLT2 inhibition, and how many of those patients are receiving that guideline-directed care. So it's helpful from that perspective. The second topic, slightly different than the problem list, but also important. We made a specific discharge template for the discharge summary for patients going to the skilled nursing facility from VCU. It has information that the NFAS attendings wanted to see that wasn't captured in our traditional discharge template. And so when a patient is discharged from VCU and their disposition is skilled nursing facility, this template will pop up without having to do anything if you're making a new discharge summary. I'd like you to avoid using service-specific templates, mostly because it's not going to have this information. And we do continual process and quality improvement with this template to add things to the template that need to be added. For instance, there was a recent serious safety event for a patient who I think they were receiving tube feeds, and their tube feed orders weren't in the discharge summary. And so we changed that print group, and now all of that's going out to the facility. So we make changes based on quality investigations. If you don't want to use the discharge summary template, there's instructions at the top of the template of how to get rid of it and what to add. So I'd encourage you to not use the service-specific template. And finally, just a plug, we have something called the Physician and Provider Builder program. At VCU, it's an EPIC program, actually, where you can learn how to update and configure the EPIC medical record to basically do almost anything you want. If you don't like how something looks, instead of being frustrated, you can learn how to change it yourself and not have to go through IT and wait for a while because they have a lot to do. So if you're interested in that, just let me know. There's a CME associated with those courses. So that's it.
Very cool, Mike. And we are on time. We all timed our bits to see if we were going to make it through. Yeah. So I get the last couple of words. It took me 6 minutes and 40 seconds this morning. I just want to say, when Mike came to interview, he told me that one of his sub-interests since high school or college has been application of informatics to healthcare in general. And wondered if he might have an opportunity to explore that once he came here. And I said, well, yeah, probably figure something out. So that's turned out to be one of the better decisions I've made in my span of time as an administrative doctor. It is a very complex environment, the management of medical information in the electronic environment. We work in my world, in multiple electronic records. So the nursing homes are in something called PCC. The home health agencies are mostly using home care, home base. And then we have, facilities in town, HCA is using Meditech, and it's kind of hard to find your way to what you need to know unless you have a really structured and well-organized system. So Mike has been really very helpful to us in this effort, which turns me to the original list of reasons why we're doing what we're doing in geriatrics. I said the first 3 reasons: better care, and better care. And then I put at the bottom efficiency and lower costs. So way back at the beginning, I skipped med school classes and went to economics classes on occasion because I was kind of interested in a variety of things related to health policy and payment, including rationing and all sorts of things in that world. Subsequently found out that figuring out how things get paid for is really important to success in providing medical care. And I learned a lot more about that as I started making house calls and getting paid next to nothing by Medicare. Spent several years trying to fix that. And then ultimately looking to find a way to finance team-based care of complex populations. There are a couple of different models that have been implemented to do that. And the challenge of it is to demonstrate that what you're doing is actually better than usual care. In order to demonstrate that, you have to have a goal, a target, a reference point, and the electronic health record is the central source of that information, the problem list. So CMS benchmarks our work against a database that they accumulate over the span of each year, measured in something called hierarchical condition categories. Way too complex to go into in any detail here today, but suffice to say that that's the way that we evaluate all of this stuff. CMS, the government, has determined that they want most of healthcare to be paid for using some type of value-based framework going forward. These are some examples of how much they would like it to be the case. 100% of Medicare beneficiaries as a goal by 2030. That's a little ways down the line, but not too far, right? 2030 is around the corner. So our model here at VCU has been to put together a portfolio of services, all designed to create a mechanism of caring for patients across settings and across time in a way that we have a better chance of coordinating the care and controlling the costs. We have participated in a number of demonstrations to see if we could sort of support that case with evidence. So we were participating in the independence at home demonstration in house calls, home-based primary care, starting in 2012. We actually helped create that demonstration through federal legislation. And it was really a pretty interesting journey because the question that was being asked is this actually better than the way things are usually? Patients coming to the office or not coming to the office, relying on the emergency department starting fresh, putting them in the hospital doing what they do, maybe send them to a nursing home, maybe not. Nursing home doesn't really know them from Adam, sends them back someplace else till they come to the next emergency room visit. So we thought we would be able to beat that system by providing continuous care and set out to essentially make the case for that. And we think that we have demonstrated that successfully. These are the criteria for entering the independence at home demonstration, which is basically house calls for patients with a set of criteria. These are patients who have been to the hospital, who had at least one form of post-hospital skilled recovery care, so a SNF or a home health agency, had 2 or more chronic conditions and 2 or more ADL impairments. So you think about it, well, that's pretty straightforward. Turns out that group of patients in the Medicare database generate something like a quarter to a third of all of the hospitalizations, the rehospitalizations, and the costs in the Medicare program each year. It's a very refined target, 6% of the Medicare population generating a third of the utilization. So very reasonable that if we were successful in managing those patients without so much reliance on the hospital, we might be able to reduce their costs. The HCC score for the average Medicare beneficiary is 1. And then you score more points based on the extent to which you have chronic diseases that are being actively managed in the problem list and acquired otherwise, but reported to Medicare basically. And so in our instance of independence at home here, our HCC score was 3.6 across all of the sites in the country, 3.1. And Christian put this slide in to help me remind you guys, how do we consider value? So basically value is some measure of quality, like what's good care, divided by how much it costs to produce. So if we wanted to produce this really great care, but it costs us a fortune to generate it, that's not necessarily going to be good value. Conversely, we could lower the cost to nothing, but produce really crappy quality. That's also not value. We need to preserve quality and lower cost. I think one of the key things, if you'll remember that pyramid I showed you at the top, in the short term, you have to do it by targeting the high cost, high risk population. These are internal data, and the numbers are really, I'm afraid, almost too small for you to see. What you'll notice though is all of those things that are in green, those are percentage reductions that occurred based on our own estimate of occurrences of care here at the health system through patients either in our clinics, in home-based primary care, in other aspects of our clinical programs relative to a risk-adjusted target. And we've been reducing the likelihood of having to go to the ER, increasing the likelihood of having more ambulatory care, reducing rehospitalizations, total hospitalizations to a significant extent. You can see here, those percentages are in the 15 to 30+% across the board. These are the results that we report from the Independence at Home demonstration. These were what the government decided they would credit us with having accomplished relative to the risk-adjusted population that was the standard usual care. Across the span of the entire demonstration, which lasted 10 years, about 7% reduction. Across the better sites, as much as 20 or 25% reduction in costs. That's what we achieved here at VCU compared to usual care. And this was with improved quality. And you can see that basically all of the sites in all of the years were successful in reducing costs in this demonstration. I'll mention two other value-based payment models that we've participated with. Excuse my laryngitic throat. At the bottom is something we're in right now called ACO Reach High Needs, which is an ACO model for patients that have been defined as having very high risk. So they have an HCC score of at least 3, plus a utilization history that suggests they are on a trajectory to reduce functional status and poor health. And we're involved with that group of patients. We're receiving capitation payments monthly and bonus payments at the end of the year if our costs are below what is expected. They've been 15% below what was expected, so we're getting essentially 4 times Medicare fee for service in terms of the revenue paid to the people in our group that are doing this work. This would be along the lines of finding a way to be paid more for doing good, improving care and lowering cost. High quality, low cost, right? Value. And we've been doing similar work with the CMS Bundles program, which is a 90-day post-hospital payment model that we're participating in at VCU Health at present with 11 different bundles. We've gained $2.5 million in incentive payments over time. And so I'm going to close out and give time for questions as we promised we would. This was pretty much of a hound dog for press when we were trying to pass Independence at Home, and we got a fair amount of visibility. I had, I guess, a little more hair. I don't know. It was certainly less white than it is now. But the patients have loved this. You know, the patients in general, these approaches to care have been very popular with patients. And we have, I think, shown evidence that we have ultimately reduced costs by taking this approach to longitudinal comprehensive care across a continuum for a targeted group of patients. Proud to be the chief of this gang of miscreants. They're really wonderful, all sorts of talents in there, and we're looking forward to whatever comes next. With that, stop and ask if anybody has any questions.
Are you in the audience?
Thank you. Hello, everyone. My name is Aditi. I'm a cardiology research fellow. I actually share some patients with some of you. And you guys just do a tremendous job. You guys have those fair conversations. Because some of the things that we totally practice
and exploring how you have the conversation and then have that transfer, that documentation transfer to the AC planning documents, which I have bounced up frustration with this Dr. So the second part of that question is, I would be interested in more information over the program, because I think that needs to be less of a barrier, because, you know, we don't want to duplicate efforts and we want to achieve very carefully, but, you know, in cardiology, you see very sick patients, so sometimes that conversation just comes up naturally, as in like for you guys to pick up. So what are some of the ways that address having those care conversation that matters most to patients in your various aspects, and then how do you recommend partnering with specialty care for doing
switch over. So I don't want to do all the talking for church. So I'm gonna hand this mic in 1 second over to, I'll pick randomly whoever. One or the other. We do have an initiative that's coming up that I think you will enjoy hearing about, which is going to be a collaboration with an outfit called Ariadne Labs, based at Harvard. We're going to be doing some work on advanced care planning and education of our workforce here at the health system that will dovetail with documentation. And I think you should get in touch with us, because perhaps you'll be interested in helping with that effort.
Yeah.
Yeah. And now.
Also, the Preference Bridge Program, Dr. Rachel Selby-Penzak had put in the chat box about that.
Yeah, Rachel, I'm sorry, the little yellow box at the front was too small. So I didn't fit in, but Rachel's got a great program where she offers advanced care planning and counseling for patients who are unsure about where they want to go with that. And she does it via virtual, so you can actually order Rachel's services. We'll be doing, I think, a lot of that. But who else would like to speak to the
So, how do you communicate chart about it? There is a place to do this discreetly in the chart where it will show up in all. SmartLink has got ACP. You put it in your note, and then whatever you type in between there will show up in the storyboard and ACP documentation. So that's how you do it. Clinically, use every opportunity we can to talk about what college. So kind of do it longitudinally with the patient.
Just to follow up, I apologize. For example, patient we have a conversation, we have the DNR form completed with the daughter in the technical room, and we uploaded it. I did that, but it didn't transfer over, and then so I sent a message to like try to follow up with all of you, like, hey, how do I do this? I don't know.
So the question was, the DNR form was signed, scanned in, but never made its way to the chart.
Correct.
It's a process problem. Yeah. But you did the right thing.
Thank you.
Any other questions from the audience? Okay.
So some of these patients are actually seeing a lot of times that travel or it'd be interesting to the numbers. Sure, that's the question.
This work. Up to. Okay, so the question was, how many patients are we seeing per day in primary care and, with travel time? And so our goal is to see approximately 4 patients in a day. Typically that can make for actually a pretty full day with capacity to see another urgent or, follow-up, but the goal is at least 4 patients a day. So we have all kinds of different ways. Some of us dictate, some of us type during the appointments. Sometimes I try to do things real time depending on the setting. You know, you never know what. There are some patient houses that you can very easily document, and then some where you have no reception, and so it varies from house to house. But we typically do a good deal of documenting back from the office and in our car offices as well between patients.
So I just want to thank you all for the presentation today. Amazing that you kept on time with so many speakers. That's impressive. But also I want to thank you for the innovative ways you think about taking care of patients. You know, I think you are very innovative, and I think you're leading the entire health system in some of these areas. And so I think if people have been listening to this today, I think we should think about how we use your expertise to care for other populations of patients, because I think there's a lot of opportunity for the future. So you do this very quietly, and I think you're a very atypical division because you are mostly not at the medical center. You are out about in the community, and it's easy to not realize the great impact you have on our patients across the system. So thanks for all you do.
Well, thanks, everybody. Appreciate your time.